Hello everyone. In this video I will be talking about the normal ECG. First up we have the three basic laws of electrocardiography. The first law states that if the direction of depolarization wave is towards the positive electrode, there will be positive deflection, or if the depolarization wave is towards the negative electrode, there will be positive deflection. Second law states that if the depolarization wave is in the direction of negative electrode, we have negative deflection, and if it is at 90 degrees to the electrodes, we have biphasic complex, that is positive deflection as well as negative deflection. Then discussing about the conduction system of the heart, we have the SA node, then the AV node, followed by bundle of His, the right bundle branch and the left bundle branch. Left bundle branch is further divided into left anterior fascicle, left posterior fascicle and the septal fascicle, and these fascicles further give Purkinje fibers which supply the ventricular myocardium. In the previous video I had talked about these basic waves and complexes of the ECG. Here we will be discussing about the origin of these waves. First up we have the P wave, which denotes the atrial depolarization. So SA node generates the electrical impulse and it traverses the right atrium and then moves on to the AV node. The direction of this depolarization is towards the second lead more or less. So we have the positive deflection in the lead second and negative deflection in the AVR lead. The ascending portion of this P wave depicts the right atrial depolarization and the descending portion depicts the left atrial depolarization. The atrial repolarization, which is depicted by the TA wave, it has small amplitude less than 0.1 millivolts, and this is masked by the QRS complex. So in the regular ECGs we are not able to appreciate the atrial repolarization. However, there are a few conditions like acute pericarditis, atrial infarction and AV block in which we can quite easily discern the TA wave, that is the atrial repolarization. Then we have the PR segment, which denotes the AV nodal delay. This is for allowing both the atria to contract, and only then the ventricles can contract after the complete filling has occurred. Then we have the QRS complex. We have three phases basically. We have the interventricular septal depolarization, the depolarization of the major mass of the ventricle, and the depolarization of base of the heart, which respectively denote the Q, R and S waves. So we have three states of this origin of QRS complex. In the first stage we have the depolarization of interventricular septum. The direction is towards the right side. So in the lead V1 we have positive deflection, that is the R wave, whereas in the V6 lead we have negative deflection, that is the Q wave. In the second stage we have the major ventricular depolarization. As we know that the left ventricle is more bulky than the right ventricle, it's much more thicker, it has more myocardial mass. So this deflection or this QRS complex, in the V1 we have the deep S wave and in the V6 we have the deep R wave, as this QRS axis points towards the left side. And the third stage in which there is return to the baseline. Then there's a concept of naming of the QRS complex. So what you need to remember is first negative wave is the Q wave, the first positive wave is the R wave, first negative wave after the R wave we call it the S wave. Then we have the normal R wave progression. What happens is there is increase in the amplitude of R wave when we move from V1 to V6, while peak is usually seen at V5. At usually V3 to V4, the amplitude of the R wave equates with that of S wave. This is known as the transition point. If it is late, we call it the late transition zone, or it can be early transition zone. In the anterior wall myocardial infarction, what happens is the anterior myocardial cells, they die, so the R wave progression is reduced. It is usually if the R in V3 is less than 3 millimeters, we call it poor R wave progression. Here in this diagram, there is a summarized version of the entire origin of these waves, the P wave and the QRS complex. Here V1 and V5 leads are shown. We can see the generation of the potential from the SA node, then the depolarization of the right atrium, then propagation to the AV node, and the three phases of the ventricular depolarization, denoted by 2, 3, and 4 as the interventricular septal depolarization, major ventricular depolarization, and the base of ventricular depolarization. Then we have the ST segment. It denotes the interval between the ventricular depolarization and repolarization. It is normally an isoelectric line. If the flow of current is occurring, it is known as the current of injury. It is usually typical for myocardial infarction. Then we have the T wave. It denotes the ventricular repolarization. As I already depicted, that if repolarization is in the direction of the negative electrode, there will be positive deflection. That's why T wave is, we have positive deflection in T wave. Then U wave, it is the depicts the papillary muscle repolarization. There are a few conditions in which we can have U waves, like it's characteristic for hypokalemia or the use of antiarrhythmics like sotalol and quinidine, or after cerebrovascular accident we can also have U wave.